It's not quite as much of a question. Now can you hear me?
Mm-hmm.
Okay. As we're talking today about transforming healthcare, looking at infrastructure, we're not going to do that without engaging the patient and the patient experience. So could everybody comment on how do we use all this great new access to information and infrastructure to truly engage or activate the patients in the care process?
And that was actually one of the comments I was going to add from all the good ideas that everyone else up here has mentioned, is that we really do need to empower the patient, and giving them the ability to have data and transparency is a huge part of that. For some of the providers who have electronic medical records with patient portals, I have found that to be so empowering for patients' care. If patients can access you, if they can easily access the office and make their own appointments, when they're sick, they don't have to wait to get through to somebody. If they can see their own numbers and follow that and work with their provider and the whole system as a partner, that is a huge step that I think we haven't seen before, is to give the patients that power to have their own data, to have transparency, to see what's available throughout the city. A huge step that we can take forward.
Yeah, I don't mean to be glib, but so about 4 years ago, my kid's got asthma, Zach, and I'm picking up his script at Kroger, and the pharmacist says, "Do you have your Kroger Plus card?" And I'm in benefits, and I'm like, "I don't think I get a lower copay." I said, "What? Why do you want it? Do I get a lower copay?" She goes, "No, fuel points." Oh, here you go. I think if mom, dad, and the kids understood the opportunities with their data, I think we're overestimating HIPAA. Most people put 2 P's and 1 A, and there's 1 P and 2 A's in case you didn't know. So I think we cannot breach that trust at all. My mom, I always test this against my mom, 69-year-old, living in White Oak, and she's a conspiracy theorist, but every piece of mail she sends is touched by the federal government, for God's sakes. She used to make calls on party lines. Now she's Skyping in on email. I think we cannot compromise it, but I think if we unleash the consumer, we got a good thing going, because mom will be in charge again. So.
When was that ever not the case? Just step to the microphone, please.
Just one other comment on the patient engagement and why I think it's important. I think the physicians and the providers have a real challenge in the cultural milieu that we are in the United States. I mean, everybody believes in the U.S., or most people, you can solve it with a pill, and if you can't solve it with a pill, then I need an MRI to find out what it is, et cetera. And if, if I don't get that, then I'm not getting good care. And so you think about the challenge that we have in trying to reduce unnecessary testing that's not supported by evidence-based medicine. It's huge. And I believe that if you can't engage people in the quality of their care and taking some responsibility, you're never going to engage them in a very effective conversation about why you do or don't need those tests and what else you could do about it. So there's in developing engagement, you develop trust in that relationship, and that's the kind of trust that you have to have in order for our providers to be effective in being able to not do some of the testing that we know doesn't add value, but it certainly makes people happy. And I think it's sort of something that we're going to identify as we get down the road here. We'll make certain progress, and then we're going to say, gee, we ran into this cultural barrier where everybody wants all this stuff.
So I've heard a lot today about transition in care, EMRs, ACOs, and all these things are within our organizations. I work for UC Health, and that's a big enough culture change as it is, massive. And we're taking a business model from the 1800s where people break and clinicians fix them and switch it around to keeping them healthy. And we talk about the patients accessing data. But my concern is that the patients, the population, have no idea what we're doing as an industry. You know, they read about these things in the headlines, they know there's healthcare reform, but if you ask 100 people what a patient-centered medical home is, bet you 2 know what that is. So how are we going to embrace these patients, get them to use the data when they don't even understand the concept of what we're doing?
Panel?
So again, I live in the world of analogies because I don't get health care either. So look at telecom. Look at finance. I got undergrad in finance from Miami, graduated in '88, senior year. Value line is what we used. Anybody finance majors? It's a telephone book with data. So let's compare Merck versus Pfizer. So you get out the telephone book, MRK, boom, got it. Static charts, PE ratios, all this stuff. It's a telephone book. Let's compare it to Pfizer. PFZ, Merck. What do you think? Okay, great. Nobody had financial advisors back then. Only the rich guys had brokers, right? Everybody else had checking accounts and money market. Where are we at now, right? Everybody had pensions, right? You don't understand finance. You won't get it. You just leave it to the professionals. Wall Street, you know, this is complicated stuff. Fast forward to now, it's like, get out of my way. E-Trade, Yahoo Finance. Yahoo Finance is cool, right? Those are dynamic charts. You don't need a broker. I'm not saying healthcare is easy. You still need to interact with the healthcare, the finance system, right? But they made it consumer friendly. There's amazing things that the healthcare system does, but it's not all rocket science. If you manage your blood sugars, manage your blood pressure, go for a walk, get your cholesterol under control, we'll tackle metabolic syndrome, and we could do some big things. And we could focus on the really important stuff. So give us a chance, and I think we might surprise you.
And I would also say that patients don't need to know all the acronyms as long as the results happen. And it might start out with the relationship with their provider, that they don't need to know that it's a medical home or that it's going to be part of an ACO neighborhood, but they know that's the person where they have their point of access. And if I have my 78-year-old who says, yeah, well, of course I email my kids, my grandkids, you know, can I send you an email with my blood sugars, and will you address them today instead of waiting for my next visit? So if they're going above 200, I can make an adjustment, and you can tell me what else to do. I think, as Craig was saying, I think consumers are ready. I have patients across the spectrum saying one more way for me to take care of myself.
I don't know that this is right or not. So you're going to give this all to the patient, okay? And that's a great thing because I'm a patient also. But the problem is what happens to my physicians that have went to all the school that have worked so hard like you to work with these patients? How am I going to get paid when they do it over the internet? How am I going to make any income? Where am I going to get the income? I understand that the patient is important, but my physicians have been doing this for years. And now all of a sudden, you want to take half of that away and half of their income. Now what do they do?
And that's why we're going to go from visits to total care, that I'm caring for my whole population, and hopefully the insurers and the employers will start paying me for that, that will be a greater percentage of my income than just this episodic care.
Okay, but isn't part of that still back to maybe the HMO system that was supposed to be a total care and flopped?
If you can text my employees and keep them healthier than having to schedule an appointment 2 weeks out that they keep pushing out, knock yourself out. I'll pay you for the A1Cs down. I'll pay you for outcomes.
But you're one of the few that will.
But that's our job, is to bring the paying community to the table.
That's our job. You're also a large employer. Okay.
And we have United as one of ours. So
that.
United, bring your insured book to the table.
But it's still the same thing. You had this home care almost in the HMO system. They tried to keep them all in the same place and do this, and that didn't work because then they got stuck in that one mode and they wouldn't come out of it and go for the competition and go somewhere else. And when they did, they got penalized. So you're back to the same system.
Well, and I think the idea of the ACO is that the consumer still has choice. If they come see me and they think that, you know, where I refer them to at Mercy is going to give them the best care and the best deal, they can go there, or they can go to B North, or they can go to Christ, and they can look online, and if they can get some of these numbers, then they send me an email back and want to discuss it. That could work great as long as me caring for that population is going to take place. If I have to bring each one of those people in for a visit to have these discussions, then I'm going to keep bringing as many people in, but some of those people aren't going to reach me today then because there's only so many visits. And there's definitely not enough primary care providers.
No, there isn't. No, there isn't. But I just feel as if you just have to be careful because it works for both ways. It works for the employer in a certain way too, but it also has to work for the physician. And there are a lot of small physicians that have 3-4 physicians. Some of them have 13, but there's a lot out there that are still the family physicians that have been working with these people for years. And you're going to take still, even if you bundle, you're going to take a good percentage of that income away from them. They're going to have to close down or get out of the business. And there are a lot of physicians that have already done that. So you have to be careful with your reforms and your health care too, because it's not just the patient. They're very important. I understand that because we do everything to make sure our patients are taken care of. But I also have physicians that I have to take care of.
But at the national level, PCMHs are finding that they're getting a new revenue stream, but the offices are also becoming much more efficient. They're actually seeing more patients, their revenue's increasing double digits, and their margins are increasing double digits.
I don't know. I'm an office manager, and I go to office manager meetings, and I don't see any of those office managers saying that about their physicians.
Well, we'll get you the data.
Yeah, we must just be the little people, because there's a lot of little people out there that are getting hurt.
Yeah.
And, you know, I understand the reforms and everything else because I've been in the system long enough, but all I say is I caution you, as you say, patient is first, and like I said, don't misunderstand me, they are. But you also have to look at those practices that have worked years to get where they're at and pull all that away from them also. So it's just a comment.
Thank you.
Just to acknowledge some of the points you made, I think one of the difficulties with all of this QI work and payment reform work is that it requires a very significant investment by the hospitals, by the systems, by the practices to invest in the QI and IT infrastructures to manage in this new world in terms of QI and surviving under the payment reform models. And part of it is how well you execute that work. You're trying to determine whether you can confidently glean those shared savings that are lagging in terms of being downstream benefits of all this upfront investment. And I don't think we know as an industry yet whether all of that incremental investment upfront in QI and IT, it's all for good purpose certainly, but what is the net financial impact 3 years, 5 years later? Will you recover? Even if you did everything well, will you recover in a way that allows you to sustain yourself financially? And part of it is a risk because due to contextual factors, your payer mix, other factors somewhat beyond your control, you may or may not do as well under those payment reform models, and the payment reform models may not accommodate, due to risk adjustment issues, payer mix issues, the challenges that you naturally have in one practice versus another that may impair your ability to recover your upfront investment. And I think that's something we're all hesitant about, we're all wondering about, because nobody knows the answer to that. So it's kind of like a bet you're making. It's a good bet because you're doing the right thing for the patients. But where will you be financially downstream? I think that's, you know, a tough one for a lot of groups and hospitals.
Okay, we have time for about one more question from the audience, if there is interest. Okay. There we go.
So you give the patient their results back, or they're able to go and see their results. What's going to be the follow-up back around to keep patients from self-diagnosing themselves and from treating themselves? Apart from, because you've lost, when the physician gives the patient their data back, or their results back, you're also providing some professional advice with that too.
Just make sure that we understand each other. So when I'm talking about giving patients the results through a patient portal, it's patient, they get the results and there's a comment and a message from me that I'm typing out, which if I wasn't doing that, it would likely be going through my medical assistant. I'd be typing it out, you know, sending it to her. She'd be calling them, and sometimes some things can get lost in the translation. So patients just don't have access to their data, such as if I ordered a CAT scan, they don't get to go in and look at the CAT scan and say, oh, I must have a brain tumor. The results would only come from me. But I'm talking about that they could follow like what their LDL cholesterol has been and what their hemoglobin A1C's been, look up their weight trend, say, so, how have I done over the last year, those kind of results that they can take action on. They said, oh, the doctor said, this is why I have to exercise more, or if my numbers aren't coming down and my weight's not coming down, I'm going to need to take another medicine. So it's giving them that kind of power, but they wouldn't have access just to see tests without medical input.
Okay, any panelists have closing comments that you're dying to make here? Okay. Thank you for your attention. Please complete your evaluation forms, and if you'd be so kind as to go out and visit the vendors during the break. Remember, if you get 10 or more dots or whatever on the sheet, you could win a wonderful prize, including an iPad. If you want more information about meaningful use, please see our table out there with HealthBridge folks that are from the Regional Extension Center. And I'd like to really thank our panel for their very insightful knowledge and responses on these topics. So thank you. Okay, I didn't have to figure that out for a while. I wasn't sure if it was